Well, a very warm welcome to everyone to the first half of our conference on future health and care in Cornwall and the Isles of Scilly, and very many thanks to all of you for giving up your time this morning. Start by introducing myself. My name is Nigel Mawson. I'm currently the chair of the Citizens Advisory Panel hosted by NHS Kano. I've been involved in healthcare issues for many years in many ways, and also, of course, I'm a patient with rather more active involvement in various aspects of healthcare than I'd like over the last couple of years. Fortunately, I'm still here. It's unfortunate in many ways that, for reasons which I hope everyone understands, we have to hold this as a virtual conference. So you can't really see in detail who's here, but I can tell you I'm really pleased to be able to say that we had about 80 people signed up. See, we're a bit short of that number at the moment, but hopefully they'll log on during the sessions. But from a really wide range of interests, members of the public, members of patient participation groups, representatives of voluntary organisations, disability organisations, campaigning organisations, various parts of the health and care organisations in Cornwall, councillors, community representative, politicians and their representatives, a really broad list of people interested in this, united by a desire to see the very best care and outcomes for the people of Cornwall and the Isles of Scilly. So welcome to everybody. I don't need to remind you how busy everyone is and how much pressure everyone's working under. So simply thank you all for everything you are doing. As you know, we felt we should divide the day. We'd originally planned into two, rather than ask you to spend a whole day, or probably for many people another whole day, looking at tiny screens. We'll let you know as soon as we can when we'll be reconvening, and I hope most people will be able to join us then. Certainly we don't see the second day as any less important than the first day today. Second day, there'll be two main topics with probably more of a workshop format. Firstly, we'll be talking about the use of new technology in health and care in future. We've seen some very rapid developments and changes in recent years, but particularly during the pandemic, and some of it, as I know from personal experience, has worked very well. Some of it less so, and not welcome by everybody, and some of the questions we've had in advance are quite challenging on that subject. So that will be interesting. And the second topic, when we reconvene, will be future public and patient citizen engagement in health and care here. We hear a lot about its importance from government, from NHS England, and from all sorts of senior figures, and I don't doubt their sincerity for a moment, and the words are really encouraging. I've had some conversations recently with John Gavett, who chairs our integrated care system, and I know he's determined that the warm words should not just be tokenistic, but must be turned into a real sea change to ensure that patients and public are right at the centre of health and care planning and provision. So that is an excellent opportunity. Making that happen is going to involve all of us and many people who we haven't yet reached effectively, or perhaps only reach when something goes wrong. And good engagement should make it less likely that things will go wrong. We're not going to please everyone, but we can make sure that there is effective dialogue and good understanding of why decisions are taken, and we can do better, and we should do a lot better. So that's all for next time. That'll be chaired by Nikki Kelly, who's a member of the CCG's governing body, who has lots of involvements in public engagement issues and does come to the Citizens Advisory Panel. I'll leave her to introduce herself next time. Unfortunately, I got a message this morning that she's not well, so she's not able to be with us. So she's going to have to listen to the recording of what happens this morning. Today we're going to concentrate on the future of health and care here. Let me explain how it's going to work. Firstly, we're fortunate to have two speakers, Kate Shields and Rachel Wigglesworth, who we are exceptionally lucky to have given the pressures of the moment. Our first speaker will be Rachel, who, as I'm sure you know, is Director of Public Health for Cornwall Council. And as such, she and her team have been very, very much involved in the fight against COVID. Much of that is in her annual public health report, which I commend to you. And improving public health is obviously a central ambition going forward. Rachel will be followed by Kate Shields. Kate was, as you probably know, Deputy Chief Executive and Chief Executive Royal Cornwall Hospitals Trust from 2017 until very recently, when she became Accountable Officer of NHS Kernow, our clinical commissioning group. And she's also worked, I gather, as a registered nurse and mental health nurse. So not just behind a desk. We've also got a strong panel on hand, and I hope they'll be involved in answering some of your questions. We ask for questions in advance if possible, makes it easier to prepare. I'm very grateful for the broad range of questions that we've already received. That's made it easier to group questions into some broad areas so that we don't have to jump about from topic to topic so much. So some of the questions have been grouped into single questions to avoid confusion, and we'll deal with all those live. But we still welcome questions during or during the session. If you could type them into the question and answer bar, and questions that get there will be responded to publicly during this session if there's time, by the team or in the panel. If not, we'll look at them, or somebody will look at them, and a reply will be sent later. So there's a commitment to answer all the questions, and for clarity, answers will be sent to each questioner and also published on the website. And could you also note that the session is being recorded, and the recording will also be on the NHS Kernow website shortly after this event, along with a full list of questions and answers taken from the event. So this is a great opportunity, but it's not the only one. Questions following the event can be sent in through the Contact Us email address, which can be found, I think, in the question answer bar, kccg.contactus@nhs.net, or on the NHS Kernow website. And I should also emphasise that all of our principal health bodies and the councils meet in public, so anyone can go along to that. The procedures do differ quite a bit, but they all take public questions. So there is very definitely an ongoing opportunity to raise questions with all of them, and this isn't a one-off opportunity. It's it's just a punctuation mark in a continuing process, which you can take advantage of as you wish. Also, finally, ask for your understanding if I mess up the technology. I've hosted large gatherings on Zoom, but not previously on Teams, so I may well get it wrong, and if I do, it's my fault. And the last thing I have to say, I suppose, before I shut up and move on to what you really want to hear, is to thank all those who have been involved in helping to organise this, particularly to Ben Mitchell, to Laura Patrick, to Louise Moore, and to Pete Young from RCHT, who stepped in fairly late in the day to help us out when Bill was ill for a spell, which got us very worried. Thanks to all of you. And with that, I think I'll just hand over to Rachel, please.
Thank you, Nigel. finally got off mute. I do hope you can hear me. I've got a slight delay on my side, but I want to start off by a huge thank you for inviting me to speak to you. Absolutely delighted to be able to talk a bit about not only the experience and learning from the pandemic, but how some of the key sort of reflections on the last few years can really help to inform the way forward for Cornwall and Isles of Scilly in our new integrated care system, and also, you know, wanting to really emphasise that we're not just talking here about health and care services, but I want to be able to bring this perspective that well-being and how we live and the conditions in which we live, as well as services and a whole range of other things, are the important part of how well we are, how resilient we are, and therefore how services should be delivered to us, and in the way in which they should be accessed as well. So I'm going to use the experience of the Director of Public Health report, which has just been published, to bring out these themes and to just talk through some of those things and reflect as we go through on what we might learn to apply to our discussion today. So just moving on to, and I'm going to probably do the whole Chris Whitty, next slide please, to the driver who's behind the scenes. So this is the report, and I'm not going to go through it all in detail. It will be available there on the link to access, but just start with recognising that the COVID pandemic in the last over 18 months now has been absolutely the most sort of biggest crisis I guess any of us would have lived through, a public health crisis. You know, all of those of us working across the public and voluntary sector and private sector living in Cornwall, everyone has been affected by the way that we have had to live within lockdowns, the way in which we've had to worry about our family and friends and respond to what was a huge call to action. So I think, you know, it's really important. I wanted to use this space to share some of that with you, and I might get a bit emotional because, you know, this has been living, breathing, and this is not just me. You know, obviously everyone who'll talk to you today, everyone listening here has their own personal experience, and those experiences have been very different. And I think, you know, some of the ways in which we've responded to this have really shown the positive sort of resilience of Cornwall. And other aspects we need to really think about and reflect on how this pandemic has affected particularly the most vulnerable. And I know we've all thought and talked about this through the pandemic. I hope you've heard that, and I think we've pulled together, but we need to really move into thinking about how we actually address those issues and build on the strengths. So if we move to the themes, or some of the themes that I want to draw out in the next slide. You know, and the report that I've put together, which you can read in detail, does actually explain and relate to the pandemic up until the 31st of March 21, so not to present day. But what it does do is really look at that inequality. So I wanted to really draw out the themes of how people were negatively affected, where were the strengths, and the need to build back fairer. So this is a sort of theme of the report. How can we actually make significant changes both in the way we live, think, deliver services and engage with our populations that we can really learn from. And this spirit of on and haggle, so my first Cornish, is really sort of drawn out through the report. And if there's one thing you can take home and you probably feel is that, you know, living in Cornwall has a particular spirit of community. It has extraordinary strengths within the people that live here, both in the skills, the compassion that's been demonstrated. And I think we would do well to really recognise that and think of ways in which we can build on that, both to improve our well-being and also support how our services are delivered and use all those assets we have to bear. And then in terms of the incredible sort of response from individuals, families, communities, businesses and larger organisations, and crucially how collaborative working, how the real, you know, purposeful linking together of people to help others through using local knowledge and local networks has, I think, in Cornwall really been extraordinary, and perhaps has led and protected our communities and our health through the pandemic. So some of those themes are throughout the report, and I'll reflect on some of them then as we go. So just in the next slide, I want to really draw out sorry, these are the recommendations, which I'm not going to go on in detail, but to signpost you to look at those, and will refer to them, sort of some of them throughout. But the next slide we have was around the unequal impact on health. So in Cornwall, you know, as I've started off by saying, we know that people, many people live very well. We have some really good health outcomes, some really good life expectancy. That pre-existed the pandemic. We've got a huge range of information that we understand about different populations and how some of them have much better health and life and healthy life expectancy, live shorter time in disability, and have better sort of opportunities. But the pandemic did actually really also demonstrate that. So, you know, we can show that, you know, the cases within Cornwall of those that we know more cases have been in women. We know that perhaps the mortality was higher amongst men. The report that I've done demonstrates a lot of the analysis around that. But what I want to just highlight in showing some of these slides to you, if we move on to the next one, is that, you know, one of the key things in inequality is how it can divide up across sort of different groups. And this is just showing in deprivation groups, which is made up of a whole range of factors. But if you divide our population into 5 equal parts, and you look at the outcome for the 1 is the most deprived, sort of 20%, and the 5 is the least deprived, 20%. But even in COVID, there were disparities and differences in death rates for those that had COVID in those groups, and those in terms of death rates. So it's very stark. This is just one indicator, and I think we need to recognise that, you know, the 20% and sometimes even the 40 and 60% of our population are not having as good health, are at risk compared to other parts of our population. I mean, COVID itself, risk factors for that, we, you know, probably most of us know, but you know, old age, multimorbidity, obesity, other factors that we'll still discover about genetics, there's ethnicity, a whole range of factors that will have affected people's sort of susceptibility to COVID becoming seriously ill. But these sorts of things also have a huge impact. And if we move on to the next slide, the reason I wanted to emphasize this is that these sorts of things have a real sort of impact on not only the population in terms of the unfairness that this brings, but also that it also drives demand in our health sector. And I think we really need to readjust and get to grips with the fact that there is unnecessary, unequal and demand and poor outcomes in health. This slide just shows, it's another way of showing an example, which is the disability-free life expectancy. So people who are living without disabilities, living sort of relatively healthily. It's a national sort of example, but people in the most deprived groups there at the top row in red live a much shorter time without disabilities compared to the bottom, and that's the bottom 10, sorry, the least deprived 10%. So that's sort of what we call a gradient. There's all sorts of ways in which we can look at this, but just an example, very stark, you know, as you are least deprived, much better chances of living without a disability up to 65. And that we also know that the most deprived groups have on average 15 years onset of these multi-morbidity, which is lots of different health conditions. So that's not a factor of genetics, that's not a factor, you know, sort of chance. It's a very clearly described sort of population and epidemiology that public health understand very well. And I think it's really important that we bring this into our understanding of health. And this is just deprivation, but I can show you a similar sort of example of that for people with mental health problems, because we know that they have a 4 times higher death rate in under 75 years. So lots of other groups also, you know, could demonstrate this. But I want to continue on my theme. If we move to the next slide, around how also a different way of showing this. But again, in these graphs shows the least deprived to the most deprived, a higher rate of emergency admission for something called COPD, chronic obstructive pulmonary disease, respiratory diseases that have a really impact on people's lives and their need for support in health settings, in care settings, very associated with smoking, but clearly other reasons. But you know, there are avoidable diseases that affect people and particular groups that lead to an increase in admissions and need for care that we would need to shift our health service to be thinking about. And that's, as I say, clearly demonstrated before COVID through these sorts of examples, but I've also shown you that that the COVID pandemic operated in exactly the same way. So I think I've made my point there. So we'll move on to the next slide. So also wanted to share with everybody, this is actually a picture from the Health and Wellbeing Strategy, the 10-year strategy for Cornwall and the Isles of Scilly, which just sets a scene around what are we talking about when we think about health and being healthy, not just the delivery of health services, but also what contribution other things have. And that person that's shown there is divided into percentages of what really contributes to the health. And this is really well evidenced and really sort of consistent in the studies that examine this. 40% of our health and well-being is determined by socioeconomic factors. So, you know, do you have, you know, sort of education level, whether you are employed, whether you have a good level of income. So all of those elements, you know, have a huge impact. The biggest impact. Then the built and natural environment, such as your housing, the green spaces, that also estimated around 10% of your health. 30%, the ways, the health behaviours, the fact that, you know, if you eat a good diet, you drink, you smoke, and a whole range of other factors. And then sort of quite consistently, healthcare, as in the delivery of health services and access to services, 20% of that. So in the context, where is our conversation happening in our system, in our consideration of health and well-being, about all of those things in proportion to how important they are? So I'd really guide people to be not only thinking about the healthcare, but how do we make people healthy through all of those elements and build that into Cornwall in our building back better after the pandemic. So if we move to the next slide, just a few reflections from the report around the pandemic, just for learning and sharing with you. And I say much more detail in the report, I won't go into everything, but clearly a really important part of managing our cases and outbreaks. And, you know, we have done relatively well compared to other areas through the whole course of the pandemic. You know, it was really around, you know, our outreach and engagement with people. So through our, not only through our sort of immediate public health response, but through our support for clinically extremely vulnerable, the sort of way in which, you know, our volunteers and community and voluntary sector responded to that, the way in which our COVID vaccination programme, not only, you know, hugely successful, but also really did make an effort and addressed going out to deliver vaccines in places where people could access, and made sure that we addressed inequality as part of that programme. So a lot of learning around how to engage with migrant worker populations, homeless people, people with very poor health outcomes. We used the urgency of the COVID vaccination programme to ensure that we not only protected the 9 characteristics, the nine priority areas to make sure we got best uptake through joint working, but we also used that learning to make connections across more vulnerable populations. We also, you know, sort of had very clear communications. I think it was certainly one of the, I've never been asked to do so many media interviews, presentations, you know, but it's, you know, to be able to access and message and be involved with discussions with the public, be accessible, I think is a huge learning, and where as leaders in health, we can do that. And I know Kate's really committed to doing that as well, but extremely important, and the access we had obviously was very good and was trusted. I mean, I think we had a survey done by Cornwall Council that said, you know, during that that year, the financial year 2021, people said 80% felt that the communications by, and I've only got this data for the council, 80% said it was clear or very clear, and it was a source of information for many people. You know, how can we make other channels trusted and engaged with, so we can share examples. 40,000 people clinically extremely vulnerable shielded at some point. You know, it's changed over time. The work that was done to support people, the impact of that on people, really important in thinking about the future. You know, there are you know, sort of the multiple vulnerable people that, you know, I think we need to continue to ensure that we have support programs in place and engage with for obvious reasons. So thank you. We'll move on to the next slide, which is this, you know, again, emphasising this on and haggle, this one and all approach that Cornwall had, this community resilience, and huge examples that I'm sure all of us can think of around what happened to support neighbours, families, people who are clinically extremely vulnerable, practical help, where people were setting up food banks for people. There were 120 food groups set up in Cornwall during the pandemic. Support from, you know, people who newly volunteered, and many people saying they were going to continue to volunteer to help others. And I think this importance of being able to bring that that motivation to help people in Cornwall into our health and wellbeing discussions and support that. Volunteering is great, but community and voluntary sector organisations don't run for nothing, and they use the best, they're most efficient organisations in delivering support to communities in a whole range of ways that we have. So let's make sure we make sure they're resilient and that they're sustainably funded as we're going through to ensuring that they're part of our health and wellbeing future and considered as an equal part of our important health sort of structures. Huge range of examples of partnership working, but I think that sense of it doesn't matter who you work for or what your label is, if you want to contribute, you're in. So that real equality of partnership, I think, is something we need to maintain. And I've learned a huge amount about what things like town and parish councils do, and a whole range of other organisations have really interconnected, particularly out in specific communities. So really strong work that we need to take away and build on. So moving on to the next area, this report that I've done, and I'm not going to clearly in this small amount of time talk about the impact of COVID on health and care in any real detail, but clearly there have been services that were stopped. Preventative services were stopped as well, and in terms of standing that back up, you know, haven't been such a priority. Really important that we don't that we get back up our cancer screening programs, that we get back up our other immunisation programs that could have been affected, as well as obviously the planned care, the hospital treatments, and the delay in those clearly is a concern, and we'll be working across the sector to ensure that we understand those delays to access and that we think about inequalities in and different groups in terms of stepping those back up. The commitment to the 8 inequality urgent action areas through the NHS are a really important part of our next system to address that inequity, as well as people with delayed access to health services. I think in May 2020, 42% of people surveyed by Healthwatch were saying that they had delayed seeking medical attention, and I'm sure that we're seeing some of that demand now as a reaction to that. But important that we plan to keep people well whilst people are waiting. We will have delays. There will be different ways in which we can support people as a sector. So the understanding about self-care, what helped people during the pandemic to keep them well enough. What can we learn around that and support people to do that as they may be waiting for particular treatment. And then moving on, I won't go through all of these because I know that I'm probably coming to my time, but and I've got so much to say, but I'll just move through to a couple more themes and then refer you to the actual report, which has a lot more detail. But mental health and wellbeing clearly very affected by the pandemic and the experiences over the last year. Lots of information about how anxiety and depression has increased during and in response to the sort of pressures of the pandemic, but also for people with pre-existing mental health problems. Again, another group that we know have poor health, physical health outcomes, and we have concerns about higher rates of suicide, not necessarily demonstrated now, but we may be seeing that, and certainly a demand and a resurgence of need for support for mental health and well-being, and that they could be done in a range of areas. So real important priority for building back in a recovery. And then moving on to the next place, I think I've covered this a bit in terms of needing to continue to emphasise and invest in preventative approaches, not just looking at inequality, but using sort of our things that we know help. Falls prevention, keeping people active will stop people deteriorating and potentially, having a fall and then ending up needing residential care because of that. If we can prevent upstream, clearly that's going to help improve population health as well as reduce demand for hospital treatment and care. And then the next couple. Children and young people. I don't think I'll have time to go through this in detail, but again, very important that this group of people, sometimes born in the pandemic, first early years of life, so important to keep healthy and set the opportunities for the future. And there's some clear evidence around some people that have been in home environments that aren't healthy. We need to be supporting the early years and children to have the best start. And then I think we'll just finish on the socio-economic environmental impacts. Clearly, as I've spoken through this session today, the conditions in which we live, hugely important. I made a point in my recommendation about maintaining the living wage and the universal credit uplift. Obviously, that's my view. We'll certainly, there's a need to be looking at our maintaining income, addressing crisis as we move into a period where we could have higher unemployment. People in great housing need, and certainly the council's challenged in response to supporting all people to access good housing. So there's some real risks and threats, but I'm going to finish on a positive, which is we know that so many people wanted to live differently and build back better and not go back to the ways that we were before the pandemic. And I think this is the golden opportunity to be really emphasising that. Living more sustainably, living in a cleaner sort of environment came up very high, and also being more physically active, just some of the things that people said they wanted to do. What a great opportunity for being more healthy by taking up those sorts of inspirations that people did have, and a real positive. So fantastic that we have such a good response in Cornwall. That on and huggle response. Let's build on that, and let's really address that inequality, which I think is driving a lot of our demands that could be avoidable. And then I just refer you to the Let's Talk Cornwall page, where the Director of Public Health report is put up, and will have an opportunity for people to add videos and become a sort of the memorial is the right word, a repository of things around the pandemic, for good examples, videos from community sector, other individuals, case studies that we can add to whenever people have time. So thank you very much. Sorry, I'm a bit longer than I expected. I could say more, but thank you for your time. I'm interested in any questions later on.
Thank you very much, Rachel. That was great, and don't worry at all about the time. All worth listening to, and it's already given rise to some questions. A couple for you and one for Andy Brailsford from the voluntary sector, who is also with us, and we'll get to those in due course. I suppose one of the unexpected, possibly to you, effects of the pandemic was that you'd become a star of the little screen. What I must say I really liked is that you've also involved your team in it. And they've been on the television as well, and that's great to see a team working together. So thank you for that. And I think we'll come back to the questions later and go straight on now to Kate Shields. Please, Kate.
Thank you. Good morning, everybody. So I'm going to follow on from Rachel's presentation, really just to talk a bit about what the integrated care system is. And how social prescribing, and we're hoping will play a big role in how we look after our people better across the whole of Cornwall and the Isles of Scilly. The next slide, please, Pete. So people keep asking me what an integrated care system is, so I thought I'd give my definition. It's not a national one, but I think an integrated care system that covers Cornwall and the Isles of Scilly should be an ambitious collection of people, services and resources, all orientated on improving the experience and the outcome of health and care in our most excluded and disenfranchised communities. What's really important for me is that the integrated care system seeks to remove all the things that get in the way of us working together to serve our people across the whole of Cornwall and the Isles of Scilly. So it wants us to look at structural changes, so we remove contestability and the purchaser and provider split. So we start bringing the NHS together as one cohesive service. And I know for many people, they won't recognise the words purchase and provider split. They won't recognise the gap between services until they try to use more than one service at one time, and then it becomes really obvious to them that we're not perhaps as coordinated as we might be. The ICS will encourage collaboration and sharing of resource, intelligence and pride. So I'd like us to get to a point where it doesn't really matter who you work for, as long as we work together and we are providing what people want and need, then we should feel proud about that, and new teams should form around the places where people live. One of the things that I've recognised is I know how to set an organisation up. I know how to put lines of accountability, put governance behind it. What I'm not quite so good at, because I'm not sure I've ever done it before, is to set something up in a properly inclusive way. So we need to make sure that the quietest voices can be heard the best. We need to make sure that everybody's views and opinions can be heard and acted upon. And one of the things that I'd like from meetings such as this is for you to tell me how you think we can do it. How can we make the ICS, that covers a population of 650,000 people, a truly inclusive organisation and a truly inclusive way of receiving, planning and delivering care. So Pete, can we go on to the next one? So I'd like this to really be getting to the parts of the reforms haven't reached. So we've had 30 years of health policy where we've been trying to make a difference to the needs of our most vulnerable people, and we still never really quite managed to pull it off because we get distracted. So I think there are some planning truths and challenges that we're going to have to play into the way that we are going to design the ICS and the way we want to work for the future. Can I also say we won't get it right from the get-go, so if we're getting it wrong, we need people to tell us so that we can recalibrate it. So what we're doing is received in the right way. And I'm starting to think about previous experiences I've had. I've not always run hospitals, I've worked in the community, I've worked in a charity, I've worked with homeless young people. And I think one of the truths that I'd forgotten is hard to reach communities aren't necessarily hard to reach. It's how you go about finding them and whether you've got anything to offer that people want to receive. So how do we start to look at serving the needs of our most vulnerable people in a way that they want to be served, not in a way that's convenient for us? I've also been reflecting on the fact that central solutions rarely work. I've got loads of evidence to reinforce that. And almost anything that we plan that is personal on a pan-Cornwall basis will fail, because the personal bit around it mattering for me has to be about me, not about groups of me. So how do we make sure that we are planning services around people, so it's, to use an old phrase, it's properly person-centred care. The truth that the nearer you are to an issue, the easier it is to know what might help to sort it out. So we have to trust our people, both those people who we pay to do jobs across Cornwall, but also those people who know their communities best. And in that, I'm talking about the carers of people and their families, as well as people themselves. And we know that changing 30 years of health policy will be hard, not least of which because nationally we'll be brought back all the time to our constitutional standards and the things that we need to have in place in order to be able to gain the trust from our politicians and our national leaders that we are competent to manage health services. So we're going to need all the help, challenge and support we can get, and we need, as I say, to have quiet voices speaking loudly in how we set the ICS up and how we work out whether it's giving us what we want over time. And I really want this to be a start of a dialogue, not an end point. So this is the second time I've given this presentation. And even from 4 weeks ago, my head shifted a little from where it was, because the further I get away from working in an institution, the more I realise that we have to involve everybody that we are working with, or we are going to miss the point. So the main priorities and challenges. So the integrated care system is going to be measured in a different way. So for previous commissioning bodies, be they primary care groups, if you remember those, we had those for a while, then primary care trusts, and then now we've had clinical commissioning groups. They were measured around the needs of the local population, but they were also measured on their clinical commissioning expertise. So could they plan and deliver a service on a population for, I don't know, hip replacements, knee replacements, ankle replacements, were they contestable? Did they take stuff to the market? And with integrated care systems, we're going to be measured probably on those things too, but also, importantly, whether we improve the health of our 20% most excluded and the 5% of people who become in that excluded group because of their health status. And I think Rachel's already mentioned people who've got an enduring mental illness, and they've become part of an excluded group because of their mental illness. They're excluded from services. And we need to stop that happening and make sure that they're the people that we're targeting. We need to work with people in a different way to affect change in a different way. And I think back, as Nigel said, when I was a nurse, talking to a lady who got diabetes and her control was really poor, and spending some time to talk to her about why that was, to find out she couldn't read. So for 10 years, we'd given her leaflets that told her how to manage her diabetes. We'd berated her when she came in and she hadn't read the leaflets. She hadn't read them because she couldn't read them. And some of the things that we need to do to make care accessible are really small, they're very personal, and we need to understand our people in a way that means that all services are accessible, not just some services accessible to some people, everything for all. And when I was in RCHT, we used the Fun Boy 3 and Bananarama as our anthem, so I am going to keep them with me because it's not what we do, it is the way that we do it. And that applies to employment, engagement and to planning. Everything we do, it's how we offer something which will affect the way it's received on the other side of the offer. And the reason why I'm linking all of this into social prescribing is I think our social prescribers have a way of working that, as the NHS at large across Cornwall, we need to learn a lot from. Can we just go into the next slide, please? So there's a commitment in the NHS long-term plan around specific personalised care, and I think we need to look at this and take it seriously, because our people who work with our communities, who understand the way communities work and how care can be offered, who understand how you tailor that to individual and to group need, is how we need to build upon our models of care going forward. And right from the start, I spoke at the Eden Project's conference around personalised care. If we don't get this right, we'll miss the point. And I have been bold enough to say, if by the 1st of April 2023 we're not making a difference in some of our most excluded communities, then I don't think I'm the right person to do this job, because I've either failed to bring an organisation together that is focused in the right way, or have become distracted along the way that we forget what we're here to do. So we are already starting to talk to our integrated care areas in Cornwall and to our voluntary and volunteer sector, acknowledging that the two are different, around how we could start this winter by making sure we get money to the right places. And Rachel in her annual report has got a phrase, universal proportionality, which, if I Kate Shields, it means we get the right money to the right person as quickly as possible to get the maximum difference for them and their families. We'll just go on to the next slide, please, Pete. So the role of social prescribing, and this is my own understanding of it, so if you're a social prescriber, I might not have got it right, but I think there are people who are definitely near to the issues and therefore in the best place to offer help and to advocate for people around what that help might look like. Engagement can be tuned to what people need, and accessibility is promoted. So accessibility isn't about ramps and rails, it's about attitudes and beliefs, it's the way questions are asked, it's the assumptions that are made about you before you even open your mouth. So that engagement is really important. When I say it's all about me, I would love that the only reason we are here is because you matter, and you can matter as the whole of Cornwall and the Isles of Scilly, or as a community or a family or a person, but it should be all about me, us, we matter, and building health equity from the person up. So when I first arrived in Cornwall, so I'd worked across the south of England for 3 years before I arrived in Cornwall, and everywhere I went, everybody told me old people were the problem. We've got the fastest ageing population in the whole of Europe, and that's what our problem is. And I think our old people do have a problem, that we are failing to look after them in a way that preserves their dignity and their choices and their independence. But actually, if we look at all the data around our population in Cornwall and the Isles of Scilly, it's health equity that's the issue. about whether people can access the preventative elements of health and the interventional elements of health in a fair and equal way, and the truth is they can't. So we need to make sure that people matter. And because I was a mental health nurse, I fundamentally believe that confidence building, self-esteem and self-belief are all we need for positive health status. And they are small words, but they mean such a lot. And our social prescribers do this in spades, because what they do is they're reinforcing people, their worthiness and the fact that they do deserve a good deal, and they do deserve to get access to services that they need, and that their wants aren't unreasonable. So I think our social prescribers help us to develop sustainable micro-commissioning. And I'm using a word and a label because it then means we can pass money through in a governed way, because we're not just putting money in the hands of people to give out, we are micro-commissioning in communities. And behind that, we can start to measure the impact that has on people's happiness. Happiness is really important. Happiness, well-being, and then through that, positive health it grows. So I want to harness our energy, use our collective experience, thought and power in a different way. I spent a couple of days on the Isles of Scilly last week, and I love the way that people who work on the Isles of Scilly, both experts by experience, so people who have been through services, as well as people who are developing and providing services. I love the way they harness their thought and power, because they do come together collectively to look at what they can do for their population. And then if we apply that to our communities around Cornwall, acknowledging that a single Cornwall and Isles of Scilly solution won't be right everywhere, but a slightly appended, amended, fiddled around with way of working might be, then I think harnessing that energy would be amazing. So what next? So there's a huge, I suppose, temptation that people will think this is sweet motherhood and apple pie. I think this is a really powerful way of us taking a community development approach and applying it into statutory NHS services. So systems love a status quo, and we need a reordering. So one of my pleas is, can you help? And I've talked to John Gavett, who's our independent chair, that submarines have stabilising tanks on them to stop them flipping over. And there is something around our integrated care system. How do we build in that stabilisation of user feedback, carer feedback, people telling us what it's like in terms of how we're working going forward, just to keep us true? So if you have any ideas around that, that would be great. We want to create an environment in which difference can flourish, and it will be difficult for organisations to do that as part of systems. So you need to tell us how we can do it. I desperately want us to, remove that I work for X. We work for Cornwall. We work for the people we serve. We're a public sector. We are public sector organisations. The integrated care system will be live from the 1st of April, so we're in setup mode at the moment. And if I can talk to as many people as possible around how we set ourselves up well, then that's good. And what I already know is that we've got integrated care areas in the west, mid and central Cornwall, and north and east, and they're already starting to make a difference. So the learning that they've got is helping us to shape the way our integrated care system will be set up. And I'm already starting to talk to Volunteer Cornwall and our our third sector alliance around how we can start getting money in this winter into the places that it needs to be to make a difference, and that we can become confident and grow new services out of new ways of working that actually address the needs of our population. So thank you very much.
Thank you very much, Kate. Thank you also to really good contributions to start us off, and that's great. And thank you also to everybody for the questions. I'm trying to keep track of them. There's quite a lot coming through into the question and answer bar, and we try to sort of bring them together so we don't dot from one thing to another. I'm going to start with the first group of questions that were set in, which are all around the ICS, and the sort of generic question, if you like, and I'm going to add one or two that turned up in the in the chat box as we were going along. The generic question is, how will you create an effective integrated care system whilst primary care, hospital trusts, community and social care are all subject to different financial systems? How will you ensure that health and social care runs seamlessly for the patient, placing resources where they are most needed? How will you achieve the aims and aspirations of the ICS? And I'm going to link that to a couple of questions that came in the chat. One was picking up what Rachel was saying about health inequalities and asking essentially, how do the aspirations that you expressed translate into action and into a levelling up agenda? And the other question that came in is also relevant, particularly to what Kate was saying towards the end, is Cornwall has geographical challenges. Will the ICS be sensitive to place-based care? So who wants to go first on that?
Should I pick that up first,
yep.
Nigel?
Sure, you go first.
So one of the things that will be different around funding flows with the integrated care system is that we have to form a new NHS body, and we are and that NHS body will probably be called something like Cornwall and Isles of Scilly NHS Trust, and all the money, capital and revenue, so things for buildings and things to pay for services, will all go into the NHS body. So at the moment, there are direct allocations that go to our providers based on how much they spent the year before and all the different things that move from one year to the next. So the NHS body will hold all of the money. And I think that starts to make a difference, perhaps not in the first year, but when we start to look at how we pay for things and how things called care collaboratives can be formed together. So we had a discussion around changes in stroke services yesterday. And if you think about how reablement following a stroke is carried out, it's not just one team in one organisation. It cuts across lots of different partners in Cornwall, and that includes non-statutory agencies. So bringing that together as a stroke pathway, we would probably start to put money into the stroke pathway so that we can move money around between providers. Now I think that's exciting because what it gets rid of is I don't know, I don't work for X, so I can't do Y. It starts to focus people's heads in different places. So I think that'll be difficult from year one, but by the time we get to year 3, we'll have practiced ways in which we can do this. And if I go back to the Isles of Scilly as a small community where it's possible to do some of those things really quickly, I would quite like for the whole of Isles of Scilly to be a health and care collaborative. And that we have a lead agency that is working with people on the islands around how we provide their health and social care. So that was the first bit about the money and different financial regimes. I think our relationship with the council is getting closer together. So that blur between health and social care is really hard sometimes to work out who is the funding authority and which agency is responsible. So because the council will be such an important part of the integrated care system and our integrated care partnership, which is the things that we say we're going to work together on, will be a coming together of not just social care in the council, but housing, education, all the things that we know make a health related difference. Then I think in the next 2 to 3 years, we can start seeing some different partnerships emerging across Cornwall, building on the success that we've already got in some areas. I think the other part was, Nigel, around place-based solutions, wasn't it? And we have 3 integrated care areas. So west and the Isles of Scilly, we've got mid and central Cornwall and north and east Cornwall. And we've been speaking to the teams who are already doing fab jobs in those areas, working with local people around how we set ourselves up to be genuinely facing into the communities that we serve. And that's when I say that for this winter, I want to start talking to the integrated care areas about where they think that greatest differences can be made around looking after people in what's going to be, I think, quite a tricky winter for Cornwall. So, and again, we won't get it right the first time, but I don't think there's anything wrong in trying and finding that we need to do something differently. It's the making sure we do something differently on a place-based basis that I think is important. And our integrated care areas, people who live and work in the areas where we'll be trying new things, will be the people that will be leading that. It won't be led by me or anybody in my team from a central Cornwall position. It will be supporting people to do right things in their communities. And then I get very excited about it, because that starts to bring community development work into the mainstream of NHS delivery.
Thanks for that. A couple more questions have come in whilst you were talking, so I'll move on to Rachel to talk about levelling up and how that's going to be achieved.
Lovely, thank you, Nigel. Yeah, so I think in response, yeah, that's a big question. I'm not really sure I've adopted the levelling up terminology. I like to talk about addressing inequity, but you know, as part of, you know, delivering a Director of Public Health report, it's the opportunity to raise issues. It's an independent report, so it's not a council report, it's not an NHS report, it's an independent report, and I will continue to challenge and raise these issues as part of my role as Director of Public Health. The last Director of Public Health report was on planetary health, and the update, you know, there's updates on what was implemented as a follow-up, so each report has a follow-up part of it. Clearly, the recommendations have a focus on working in partnership, so working with the ICS in its development. There's some very specific recommendations that I hope to be working with Kate and team around implementing over the next year, and also sort of working with the Health and Wellbeing Board at that strategic leadership level. But also part of this is system leadership, as Kate has said. You know, the whole the way in which systems work together when there's quite a lot of you know, sort of legislative and governance barriers is people. And if we have the right people with the right commitment to get things done, that, as we know, makes a huge amount of difference. We have got some practical input. So we've had £11 million that is for in-year recovery work to address COVID vulnerable groups. So all details of those on the Cornwall Council website. It includes work with community sector around mental health and wellbeing. It involves supporting homeless people to maintain the everyone in approach. So there's very specific funding, non-recurrent. So we'll be looking at how we can learn from some of that additional investment just this year and build on it in the future, putting business cases together. And then I think we obviously will need to see how the spending review and the budget lands tomorrow, but I'm sure we'll have some things to say about whether that helps or not helps the levelling up agenda.
Good. A couple more questions come in directly related to the ICS. So whilst we're on the subject, I think I'll take those now. First one, to what extent do you envisage the ICS will be publicly provided and provided by not-for-profit organisations? The argument that centrally organisations don't quite follow that surely applies even more strongly to large multinational companies providing social or healthcare and healthcare.
Shall I whiz down a few of them, Nigel? Because there's a few that are all...
Yeah, that's the easiest, yeah.
So the first one starts off about, we've been talking about health and care in Cornwall for ages. Is it getting any better? So one of the truths of life is that health and care has to be wrapped around each other, because people sadly don't split themselves up into nice neat portions where we can work out who's responsible for what. So yes, we are very committed to making sure that health and care is as integrated as it can be, and that might mean that sometimes that health do social care and social care do a bit of health, and that we'll just have to work our ways through that. And I know Kate Canally is very committed to making sure that we can work together in a good way for our people. One of the other questions was around innovative roles that other ICSs have got around the country. And yeah, we are going to have a Director of Digital for the county, and in that we want a platform for everybody who needs to use digital healthcare in the county to be able to, and to look at digital poverty and how we could have hubs around the county. Some of our care homes are offering that they could be digital hubs where people could go to access their outpatient appointments. rather than going into centralised places. We're also looking at a director of inclusion and a brackets after commissioning, because money is really important when it comes to developing services. And we are going to have a senior post around personalised care. And we've gone from being one of the lowest funders of personalised care in the country to one of the highest funders of personalised care. I think that's really important if you've got a long-term condition or a disability, because you are the person who should be leading the approach for your care. So we're also going to have a director of workforce who I'm resisting at the moment having a director of people, because the NHS body will only employ around 200 people. We don't need a director of people, but we need a director of workforce who understands how communities work. So what I'd like us to do is to have an approach to workforce that is working with DWP, it's working with companies when redundancies are happening, and that we're looking at a skill set across Cornwall so that we can start to layer up our workforce plans in a different way, and offer careers in health and care at times when people can access them. So I didn't do a degree when I was a general nurse. You didn't do degrees then, but by the time I was a senior nurse I had to do a master's. At that point I could fit it in with my kids. I could never have done it when I was a general nurse. So there's things about when you come in and out of formal education. Well, the question around publicly or privately funded services, it could be a really political one, and I think my answer is the ICS will work with anybody who's the best for our people. So we want to stimulate the best across the whole of Cornwall, but where we need to bring people in to do specific things, I don't know. If we've got a great big backlog in ophthalmic care, I wouldn't rule out us going to a really good out of Cornwall provider to come in and to catch up, so that we can make sure that we're looking after all of our people well. And then the last bit was around a database that talks between providers, so that people only tell their story once, and that we can all have access to the information that we need. And that is being progressed by Calvin Hipperson, who's the Director of Digital for Cornwall at the moment. So we just need to make sure that Calvin's planning for everything, not just for some things. Don't know whether that helps.
Thanks very much for that. Let me see. Yes, interesting comments too in the chat, not just questions. There's a comment here. What is very clear is that health and care cannot work alone. A lot of the inequalities relate to living conditions, housing, finance, work opportunities and environment, facilities, open spaces and so on. I'm sure that is well understood. Rachel's nodding there. What have we got here? Just looking to see what questions I've missed. Question, how will this ensure there is true joined up working? No mention so far of this unless I've missed it from somebody anonymous.
So I don't think we've used the phrase joined up working, but I think everything I've said means people will have to work together, and that is joined up working. Our most vulnerable people are the people that fall between the joins, that don't quite join properly, and that's why I think so I've worked in lots of teams in health and in a charity, and in a charity we work with everybody because we were the most appropriate person, the most appropriate place for somebody to come. When I went back into health, we got all the access criteria and who fit into our service. People aren't that neat. Services need to ensure that they can bring the maximum number of people into their care rather than limit who can come in and out. The term gatekeeping I hate, because it means that we exclude people. So I think that is a cultural shift as well as a service shift, and I would like us to be challenged around that a lot, because I think we all need to be challenged around whether we are sufficiently joined up.
Thank you very much. I think I'll move on now. It leads quite naturally into the second set of questions. And apologies if I've missed any. I'll try to come back to them as we go along, or we'll deal with those afterwards. There's a set of questions all about money and funding. which always worries me coming from a financial background. Not sure if this is in the right order. Are you aspiring to a unified health and social care budget in Cornwall and the Isles of Scilly? And then how does the funding formula work for Cornwall? And how much of the recently announced ring-fenced for 5.4 billion will be allocated to Cornwall, and how will it be administered? Will there be extra funding to cope with the critical incident? That seems to cover quite a number of areas. So if we can have a go at dealing with that, and then we'll have a coffee break, comfort break, and so on. I think that's mostly for you, Kate.
Okay, so one thing that is a truth in the public sector world is there will never be enough funding. So whatever the formula is, and whatever money comes to us for recurrent services, when I was a nurse on a ward, if you asked me what I needed to run my service, I would tell you. If you then asked me what I could get by with for a decent service, it would be very different. So our ambition should outstrip the available funds, because otherwise we're not being ambitious enough. Of the 5.4 billion that's been announced, we're currently bidding's the wrong word, I think. We're currently putting expressions of interest in for developments for winter. So we will see a community diagnostic hub start to be developed in Bodmin, which will give people in the north and east of Cornwall alternatives to both Derriford and to Trellisk if they need to have community diagnostics carried out. And that will also be pre-procedure, so they won't necessarily have to go into hospitals for all of their workup. We're asking for additional money so that we can get modular theatres, because everyone will know with COVID our available space is challenged because of the pathways that we need to run for red and for green pathways. All surgical pathways we try to keep green. So we're looking at whether we can bring in a double theatre vanguard unit so we can have some additional theatre capacity. That will mean that St Michael's Hospital will be a completely orthopaedic hospital, which will allow us to address our backlogs for people waiting over a year for orthopaedic care, which we know is unacceptable. We've also put bids in for West Cornwall Hospital so that we can have dedicated urology and office gynecology facilities. And we're also in St Michael's putting in a bid for, we get lots of hand injuries in Cornwall, so that we can have a hand service so that people can be seen very quickly. And obviously that reduces the amount they're away from work, and it helps them get them functioning faster, better. On top of that, we're also looking at additional capacity to support Cornwall over the winter period for the care of our elderly, because we know at the moment that the hospitals, bedded care is full of older people who probably would prefer to be at home, but for whom we haven't got a home care solution. So we're working very closely with social care, and we've got a plan coming together. It's got a range of different things in it, and a range of different options over winter. So potentially we might have a care hotel, we might block purchase bedded care in nursing and residential care. But the important thing for me is that we'll case manage everybody who goes into those temporary facilities, so that we can get them back into their own homes and functioning independently as quickly as possible. So there's a whole load of different pieces of work that are working over the winter period. The NHS will be redescribing what intermediate care is, and intermediate care is the bit that glues general practice with inpatient services together, whether it's for mental health or for physical health. And we will start to see some new models of care coming in place in the places where people live, because that's it's important that it's personalised to where you live in Cornwall, or yet again we'll miss the point. So I can't give you details of exactly how much money we'll get, but I can tell you that we've been ambitious in what we've asked for, and if we get what we've asked for, then we will have got a good deal for Cornwall. So yeah, there are plans at the moment.
Thank you. Rachel, is there anything you want to add to that?
Yeah, and just on local government funding, I think, you know, whilst Kate has said, you know, we've got to work with what we've got, and we always will do. I think, you know, I wanted, you know, I guess to make the point that whilst, you know, there may be some settlements for NHS, I think there's, you know, continuing pressure in local authority as well. And we don't really come out very well in terms of the funding formula. And I know, you know, you might say, well, yes, that's what it's like, but you know, we do challenge back on that. I think particularly Cornwall Council members, I think we receive 60% less in terms of per person funding than inner London, and 50% less of councils in metropolitan and city areas, whereas we know we have rural challenges, ageing population. So a formula which clearly does recognise sort of deprived communities in inner city doesn't necessarily sort of benefit us in terms of the costs for delivering services in some of our, you know, a vast dispersed population. So I think there's some real difficulties around how we're recognised, and I think the Shared Prosperity Fund as well, that may well have some announcements today, is the replacement for some of the EU sort of what is funding that previously went to less affluent regions, of which we would be and are one. So some real challenges there as well in terms of the whole sort of public sector spend.
Yeah, thanks. Thanks very much. Obviously looking forward with great interest to what comes out of the budget. One final one that's a really interesting question, but on the subject of managing money within the ICS, gatekeeping is a real issue. Thank you, Kate. NHS is a universal service. Social care is limited by eligibility criteria and means testing. How will this be managed? Good question.
So in terms of means testing, so the NHS is free at the point of access. So for NHS services, there will never be means testing. Well, I can't say there will be in my working lifetime in NHS services. We know for social care that there is eligibility and means testing, but we also know that the I forgot what the term is, but the amount of savings that you can have is going to increase when accessing social care. So it's going to be a live debate that we'll be working with as we see more integrated care teams emerging. Then I think that blurring between health and social care is going to become more blurred, and I think there will be a reality then around means testing and us being clear which parts of social care are means tested. So reablement, for example, there's NHS and social care reablement that isn't means tested at this point. When you leave hospital, you access reablement services. So I think it'll be something we're going to have to work with. There's not going to be a neat solution. Can I just pick up the community diagnostic hubs, Nigel? I've replied online. But, first community diagnostic hub will be at Bodmin, but then we are looking at Camborne and Redruth and West Cornwall Hospital as places where we would develop future community diagnostic hubs. I'm looking at Zoe as I say that to make sure that I'm exactly right. Would you nod, Zoe, if I am? Yeah, good. So that's how we'll be rolling it out. And point of care testing is really exciting because it means that if you've got a chest pain, if we get the right point of care testing in the right part of the county, you won't have to go to Trelisk or Derriford. You'll know straight away whether you need to go to hospital or whether it's something your GP can support you with.
Good, thank you very much. I think we've got and a coffee and a break. It's now what's time? It's just coming up to 11:15, and let's restart at 11 o'clock if that's okay with everybody, and we'll move on to a whole series of questions. Thank you very much for all of them, and thanks particularly to Rachel and Kate for their contributions. Thank you. Okay, I make it about 11 o'clock, so let's get underway again. We've got a whole series of topics to cover. Technology, the impact of technology, some questions there. Questions about current pressures, about Pcns, vaccines, staffing and accommodation. I had a question in the chat, which I think I love it as a question, coming from the Citizens Advisory Panel and being very concerned about engagement. If the quiet voices speak out, they stop being the quiet voices. If you prioritise quiet voices, does that mean that anyone speaking out can be ignored? I love it, but I think it's best discussed, and it should be discussed at the second session about public engagement, because we really should dig down into how we reach the quiet voices and encourage everybody, or as many people as possible, from wherever they come, however loud their voice, to engage. So I hope the questioner will understand if we put that on one side for now. So let me go on first of all to questions around technology. This the sort of generic question is, can a clinical commissioning group coordinated any guidance, training or financial support to Cornwall's GP practices for the rollout of new telephone online appointment systems, triage processes and online consultations? Why do GPs continue to advocate virtual consultations when face-to-face consultations offer more concrete examinations? And there's another question in the chat, if I can get back to it, about a common database. I can't find that for now, but it's about establishing a common database of patients' records. So, Kate, that's probably for you to start off with.
Okay, so I think there's lots of different questions in there, isn't there? So has Kerner Clinical Commissioning Group organised any training for GPs around online management of telephone, I think it was telephone triage and online appointments? And I don't know, but I'll find out. So I don't know whether we have or not, or whether it's the same training that the rest of the NHS got, which was more or less learning as we went around the use of technology. The second one around is, why are we not doing so much face-to-face when it can give more of a concrete view? Now, I think this is very personal, so I'm delighted my GP doesn't want to see me anymore, that they trust me to take my own blood pressure, and that we can have a chat on the phone once a quarter instead of me going into the surgery. Now, that suits me. I know for some people it doesn't suit them, and I think one of the things we're seeing at the moment is the dissonance between some people who like non-face-to-face and some people who don't. Our GPs are seeing more people than ever at the moment. There are numbers of appointments that are being offered and taken up, but we clearly do need to look at the needs and wants of people who want a face-to-face appointment. So I think that plays, Nigel, to your point around how we get user feedback and use that feedback to inform the way that we develop services. So I can't give more of an answer to that at the moment because I think it's a bit of an unknown. And then the third one was a database of patients' notes. So somebody in one of the questions it's put about GDPR gets in the way. It was Sue Nichols, about how we can link up the NHS with parish and town councils. Now, I think the linking of notes is a similar sort of issue because of GDPR, but we know some parts of the country have sorted it out. So Calvin Hipson, who's our director of digital, is working around how we can get appropriate views of patient records in the right places. So in the emergency department, we should be able to see general practice notes. So that is a live project that is ongoing now. And GDPR is an issue, but as I say, we need to learn from places who have made it less of an issue and allowed sensible things to be done with the consent of people around the use of their own data. Zoe, is there anything you want to say on that? Because you might be a bit nearer to that than me.
Yeah, hi everyone, I'm Zoe Greattrex, Head of Strategy at Royal Cornwall Hospitals. It was just to say that certainly during COVID, we did a lot of work around sharing more information where previously we weren't able to. And we're now doing a lot of work around population health management. and trying to understand if we can understand our data between the acute sector, the primary care sector, the council, and understand the patient's journey when they interact with all these different organisations. That's how we can really start to understand how we can improve patient care and patient pathways. And so there's a lot of work going on looking at how we can improve data sharing between all those organisations and make that data available to us all. So in the future, we can really use that as the basis for planning and delivering our services. And I think that would be one of the big changes that we see in healthcare in the future, actually, is how we use that population health management data.
Thanks for that. Rachel, you wanted to come in.
Thank you. I think, yeah, clearly the work that's being done for the population health management, it's a long word, but essentially it means, you know, using your data and intelligently to plan services and also look at different ways of doing things. You can see the contacts with people through all these different services. How can you create that that sort of approach to be more preventative, so intervene early, and also, you know, sort of address that inequality where we can see it. But there is a lot of data that we have in health and care and public sector that we need to use better. And I certainly can see as a system now we're developing a much better integrated. We've got a joint intelligence group with the really key people from across the data and analytics teams of all agencies working together. And I think it's a real positive. And also the GPs are starting to again use it where they've got the time and support to understand how their practice population is working as well, to sort of not just see the people through the front door, but work, you know, through things like social prescribing, which identify people who are coming in quite frequently for things that perhaps aren't health clinical issues, and can be supported, you know, alongside with other ways of other activities and wellbeing initiatives, and working with the voluntary sector. So it's sort of, you know, it's part of a holistic sort of approach to care. But the data part really important, and it's the technical stuff that, you know, is beyond me speaking about. But if we can get it right and sustain it in Cornwall, I think it's got a real future in helping us.
Yeah, absolutely. Good data, good IT, absolutely critical. I'm going to move on now to a number of questions around the current pressures and ways in which we can respond to that. The kind of generic question I've got is the pressure on our frontline acute services is unrelenting. Whilst acute services are under such strain, how can primary community and social care be significantly enhanced to provide such care, improve wellness, reduce the determinants of ill health, and managing aging better? And this is obviously a huge challenge. There are other questions in this area, and in a minute I'm going to ask Andy Brailsford from the voluntary sector to come in. There's a question that relates specifically to that. Is the provision of vital support services by volunteers somewhat contradictory to the provision of paid work needed to tackle economic disadvantages? So who would like to start on that? Do you want to come in, Andy, straight away? Tell us about everything that you've been doing.
Thank you very much. Yeah, I think it's important for the voluntary sector to to embrace the transformation that's taking place across health and care, and we have been working on this for quite a long time already. And I think, you know, I often talk about the 5 Ps. That the reasons we get involved are that there is an emphasis on prevention in the new approach, and that is an area where the voluntary sector is particularly strong. There is the focus on personalisation. And you know, I think that's something we do very well in the voluntary sector, starting with the person, the whole person, and looking at building up support around them. There is the place-based emphasis, which again is very important for the voluntary sector, because not all of us are county-wide organisations. There are lots of smaller organisations with a specific focus by condition or by place. And the new approach will give them the ability to engage in ways perhaps they haven't been able to before. There's the partnership or collaboration aspect. And the voluntary sector is currently working up its own model that will enable us to better sit alongside our colleagues across the public sector. So there will be hopefully a voluntary sector provider collaborative. We do have a seat at the top table, so the Chief Exec of the Voluntary Sector Forum sits on the ICS. So we're not by any means separate from and distanced from what's happening. And the final P from our point of view as Volunteer Cornwall is most important for us is the people aspect. So this is very much about how do we involve people in their own and other people's health and well-being, and that's particularly something that we've been working on for quite some time in the voluntary sector. So we're involved in all sorts of things, both at the when we talk about primary care, often people think of primary care being equals GPs, but actually to us primary care is about far more than just general practice. Primary care starts with you as a person at home in your community, living and staying active and healthy and fit. So it has strong links across to public health messaging. And then you go to see your GP perhaps when things start to go wrong, and straight away when you go to see your GP, the voluntary sector are in there. So we've got social prescribers linked to general practice right across the county, and we've been piloted. We were involved in the initial pilots for the social prescribing model going back to some 3 or 4 years ago. We've got a COVID recovery programme, so you've got the voluntary sector working alongside public health and others to support the recovery from COVID, and that manifests itself in different ways. So we've got volunteers volunteering at the COVID vaccination centres and at the pop-up clinics, and that's alongside paid staff. So we're not seeking to replace paid staff with volunteers, but what volunteers can do is add value and enhance the offer from the public sector. We're involved in work around HIU, which is a 3-letter acronym you might have come across or might not, high intensity users. So we've got a scheme that looks at reasons why the most frequent users of our acute services are people who call ambulances daily or turn up at ED a couple of times a week. What is driving that behaviour, and how do we change that behaviour? And that's been a very successful programme. We deliver that in partnership with a couple of other organisations. But most exciting for me is the investment that's come to the voluntary sector through COVID funds that have allowed us to invest in initiatives. We've got a partnership of nature-based organisations. They're delivering activities at Nuki Orchard and Eden Project and Battling On and Chaos Farm and so on. And you might think, what's that got to do with with health and COVID recovery? But actually, these are activities that will support people's physical and mental health and well-being, helping them back to recovery if they are perhaps if they've had COVID and are struggling to get back on their feet, or preventing them from ending up in the system. And of course COVID also gave communities and volunteers the opportunity to show what they can do. We talk a lot about resilience in our systems and in our communities, but COVID really showed that when it matters, people will step up and they will help each other. They will get involved. So it was really heartwarming to see nearly 300 groups pop up on Facebook, almost overnight when COVID struck. Lots of people said, right, I'm going to organise my community and we're going to do this together. And so, that really showed that when you ask people, they will step forward. They do need support. That doesn't happen magically, and they do need assistance sometimes to form those structures and sustain them and deal with all the intricacies and complexities of funding and safeguarding and so on. But with that support, we have got a whole extra level of support that we can tap into within our communities. And then we've also innovated in the sector. We're working at the moment, we're developing a pool of reablement volunteers to work alongside the STEP service to offer more reablement for more people for longer. For example, we're involved in the winter respiratory plan, so we'll be supporting people with COPD who are most likely there's a diagnostic tool that GPs can run, and it identifies within their caseloads those people most likely to present to ED with COPD related conditions. And we know that of of the 400 or 500 a year that turn up at ED with COPD, 75% will end up being admitted, and the average length of stay is 5 days. Now, if we can do something about that, you know, and that will involve voluntary sector colleagues ringing those people weekly and just supporting them in the management of their condition and working with breathers groups and so on. If we can do that, we can do our bit to help try to manage down the demand at one end, and then there's a whole host of work going on at the other end to get people back out and supported on their feet. So Age UK have got their Step Into Wellness programme, Disability Cornwall have got a bank of PAs that are providing support to free up domiciliary carers to do what they do best, and so on. So I think for the voluntary sector, this is a really exciting time. It is difficult, it's challenging to keep up with all the changes that are happening. It's challenging sometimes to think, well, where can my organisation fit in? But you know, we have places, the voluntary sector has got seats at the 3 ICAs that Kate mentioned, so the North and East, Central and the West. There are places on the boards there for the voluntary sector. There's a representative on each of those, and we are, you know, when I remember when Kate was chief executive of the hospital, she literally said, you know, the doors are open, come in and work with us. So it doesn't feel like there are any barriers to the voluntary sector's engagement across the system. If you can help, then, you know, come and talk to us, and we'll work out how that might look in practice. But certainly, if there are any voluntary sector organisations listening who are thinking I could help with something there, give me a call or get in touch with anybody on here, and we will work out the best way of making that happen.
Thanks, Eddie. It's going to put your contact point in the chat so that it's on the record, so people can take advantage of that.
I will do.
In the Q&A. Okay, Kate and Rachel, sort of questions strayed over your areas.
Thank you. Can I come in next? I mean, in terms of you know, sort of prevention and public health interventions, you know, but these are, you know, many services and approaches have been delivered and are part of our remit, but Andy has given you the community and charity sector and voluntary sector, which are hugely important in terms of that wellness and prevention activity. The statutory public health services, I would say, have fared quite poorly over the last 5 years. We've had a 20% reduction in the grant funding that comes to local government. But we still deliver some really important services that are, you know, sort of very universal. So health visiting and school nursing, everyone has a new birth visit, and really important for starting off in the journey with a new family. But we also provide things like smoking cessation services. We have a Healthy Cornwall team that is now targeted to work in specific areas of higher need. We've had, you know, some real changes to some of the services that we deliver, but drug and alcohol services, sexual health services, all responsibility of public health, all aimed at preventative and early intervention and messaging. But we also work really closely with NHS in terms of their responsibilities. An example will be the National Diabetes Prevention Programme. So clearly, you know, we have higher rates of obesity, we have high risk of diabetes and high numbers of people living with type 1 and type 2, but there are preventative programs for type 2, and that includes referral through GPs to have support for weight management and activity. So we've enhanced our ability to give vouchers for people to attend things like Weight Watchers and Slimming World, as well as our own types of provision and classes in some communities. So a whole range of work does go on, which I think is probably a little bit invisible, but a whole range of health checks for populations that are more vulnerable. Where I'd like to develop further is certainly in that activity, supporting people, particularly who may be becoming at risk of falls and fractures, that we really put some emphasis into making sure we strengthen balance. Keeping active, as Andy said, you know, living at home is really important for people in Cornwall, many of whom, you know, are sort of in older age. And I think the other thing around, we do also work with the private sector. So, you know, our workplace-based health programmes that are led through Cornwall Council's public health team, and we've really benefited from that in terms of COVID management, with good engagement with large employers who often employ sort of routine and manual workers who are a target group. We can then work with employers to help offer support on weight, diet, smoking, some of those elements as well. So there is a whole range of things in place, but as I say, I would say, you know, that needs to grow so that we balance the, what I would say, 26 million that comes into, you know, a public health team in Cornwall for the grant against the billion, you know, that we have into public sector sort of resources. So a rebalancing would be, I think, appropriate in order to sort of get that right and reduce the pressure at the front door in the long run.
Thank you. Kate, anything to add to that?
So I think part of the question was also the crunchy end of while hospitals are full and care is stretched, how can we make sure that we do the things that we say we want to do? And I think one of the realities for me at the moment is through accident rather than design, we've got the wrong people in the wrong parts of our health and care system in Cornwall. And what we need is something that helps us to rapidly right that. So there are some of the questions that are coming in the chat around care hotels and living carers. And over the next few weeks, we are going to be working with health and care, looking at how we bring a range of different things online rapidly so that we can move people who are waiting in hospital beds. There's around 200 people in hospital beds at the moment waiting to go somewhere else, whether that's residential or nursing home care, whether it's back to their own homes with domiciliary care. So we need to move those people so that ambulances can get people into the hospital. And that is going to have to be by bringing additional capacity online. We are going to have more bedded services for a short period of time. So the care hotel will be developing that over the next couple of weeks, and that will be staffed by people outside of Cornwall. It's a very expensive way of us bringing care into the county, but it's necessary. We are looking at living carers, but it hasn't been very popular, so not a lot of people have wanted to have people living in their homes, but we've had a few people discharged through that route. We've had some success with a discharge grant, which is where we've offered families up to £1,200 to make changes at home or to buy in additional care to settle people back into their homes when they go home. We'll carry on doing that over the course of winter. And of course, we are looking at how we can bring in additional bedded care. We've got an awful lot of people at the moment waiting for 4 times a day visits at home, some of those with 2 people coming to provide the care 4 times a day. And for those patients over this winter, we might be looking at residential or nursing home care as an alternative. And that's where I spoke about the case management being really important. We need to make sure that when people can go home, we make it easy to get them home so that they don't end up in another part of the system that they shouldn't be in because we haven't managed to case manage them back. And one of the questions around case management, my definition of it, having been a community psychiatric nurse, is that we will have people with a caseload and that they will be on a named person basis working out what we need to do in order to get people back into their own homes, if that's at all possible and if that's what they want. So those things are in train now, and between now and Christmas, because we're really busy now, the busiest time in winter is February and March, so this is just our warm-up. So we need to make sure that we get some initiatives in place really quickly so that we can decently care for everybody in Cornwall, and make sure that we're discharging all of our responsibilities, whether it's for people having a hip operation, somebody having cancer treatment, or somebody coming into the emergency department for an accident or an emergency. That shows how old I am. I still see it as accident and emergency. So yeah, they're the things that we'll be looking at, and over the next few weeks we'll be able to describe more of what we're doing.
Thanks very much. Thanks to all. That's a sort of very comprehensive programme. Just 1 or 2 loose ends in the question about, I think, a discharge to assess beds. I don't think we're entirely covered. I think there's some misunderstanding about that. And then the questions about the additional rate template for home care provision, and will that be increased at the same percentage uplift as the ceiling rates?
So one of the issues around domiciliary care is what's the right price to pay, and from a health perspective, we will be looking at increasing the rate of pay for people working in domiciliary care, so that we can try and make it more of an attractive proposition. We know that just what people are paid isn't the only thing that makes an attractive proposition. It's whether you have to do 50 miles a day in a car paying for your own petrol that makes it an attractive proposition. It's whether you do 15-minute pop-in visits, or whether the time you're in somebody's home is meaningful and you feel you've done something when you've left. It's whether you get paid for travel. It's what your sickness and holiday pay is like. So there's a whole variety of different things that we're looking at. And we are talking to social care constantly about how we can work together to make sure that we are encouraging people into care and making it possible for them to stay. And if anybody's got any children who are at university, can you make sure that you send the message back to them that all of them, we would like all of them to work Christmas, Easter, May half term, the whole of the summer, where they can have their pay annualised, so we can divide it into 12ths and they can have it while they're away at university, so they don't have to work while they're studying. But anything that anybody thinks makes part-time as well as full-time access to care helpful, then we'll do. And I would just like to say the only reason I'm a chief exec is because my mother made me, didn't really want to, go and work as a healthcare assistant on a female care of the elderly dementia ward, and I absolutely loved it. So instead of doing French and business studies, I jacked it in and went to do nursing. So and I had always said I was never ever going to be a nurse because my mum was and my sister was, and I'm not interested. I loved it. So I think we need to try and find more ways of getting more people involved in work that frankly is it's a pleasure to do, hard at times, but it's one of the best jobs in the world.
Thanks very much. Let's move on. Let's move on to the next question. It's quite a simple question for once. What impact will the primary care networks have on improving access to NHS services? All to do with care closer to home, or that sort of care closer to home?
Again, Nigel, because I'm just answering somebody on who they should speak to about living care, and I'm saying yes, me, and putting my email address in the chat. So sorry, could you say that again? You're on mute. Nigel, you're on mute.
Oh, so I am. Sorry, let's try again. What impact will PCNs have on improving access to NHS services? Fairly.
Oh wow, I hope they have loads of impact on improving access to NHS services. So our primary care networks are the aggregation of 15 groups of people who know their population better than lots of people. They're not only GPs and healthcare workers, they're voluntary sector workers, they are patient participation groups, they are people in local areas who knows what's what. So I'm hoping they're going to tell us, if only there was some money available for, I live in Lostwithiel, the Lostwithiel Social Services, as my GP calls them. It's a group of people who've recently retired who would quite like to carry on looking after other people. Then he introduces people who want to care to people who need a bit of shopping. So I think that's how PCNs will improve access to care around our county. And not all care is statutory and not all care is health. And actually just having a cup of tea and a biscuit is care. And that's the bit that I feel so strongly about.
Okay, thank you. Now two more, next two areas. A question about how data is gathered on patients presented primary and secondary care for planning purposes, how that's being addressed and being improved. And then after that, I'll move on to various questions about staffing and recruitment and accommodation. So,
do you want me to do data, Rachel, first?
Yeah, if you could.
So the CCG as it is now has got access to everything that we spend money on. So we know what we spend money on around Cornwall, and we've got loads of national data that tells us what we should be expecting to spend, we know what we do spend, and then there's the question about why we spend more or less depending on what it is. So we already have that. Population health management that I'm going to leave to Rachel to talk about is a way in which we understand that spend data better, according to much better understanding of who it is that we're looking after. So Rachel, can I pass over to you?
Thank you. So we talked a bit about population health management earlier. So essentially, when all of the records from primary care and other parts of the health system and social care are joined together, then you can clearly sort of see a part of the picture, which is the crossover, which previously, we often describe sort of one set of people, but not know potentially the sort of crossovers. And so that example of that might be conditions. So if somebody is living with, sort of a heart condition, heart failure, we might categorise it in this way, and we'll count all those people up. And then if someone is also type 2 diabetic, that will also be sort of counted up, and we'll have a number of people with that. What perhaps we haven't been able to do in the past is to see who has those multiple conditions and where they are being sort of managed and supported or not accessing services in our system. So population health management sort of both helps us to understand more detail about the whole population and health and how people access services. But the purpose, I feel, in using it is to really be proactive about understanding some of the groups in patients who are most at risk. So if somebody's got sort of high blood pressure, they're going to be at high risk of something maybe happening later if things don't change. So that's an opportunity then to sort of be supporting someone to be more active, to have some help with diet and weight loss if that's an issue. So you can do preventative care and then look, because the risk factors and those Pcns are part of looking at those information and trying to be more proactive. You can also then look at different ways of pathways of care, whereby, are we actually treating all of these sort of groups of people in high-end acute hospitals where they have to go in with very expensive consultants, or is there a way of moving things so that it's more community-based, because actually that's more appropriate? So it gives you a lot of information through this linking of records, and also in terms of social care, and we can build on that to include other information that then helps to plan services strategically. You might then include things like children's services, education, housing in different ways. It's all anonymized data, so it's not, no one is working on this and being able to find somebody and look at them. There's a whole machine of information governance that's been put in place to make sure this is safe and it abides by all of the rules. And I think I'm probably fair to say that's probably taken about 3 years of work to ensure that it's as safe as possible and warehoused in the right way. But importantly, it really helps planning. It helps actually people and how they may receive treatment on the ground. And there's lots of different pieces of work in different primary care networks going on to look at how they can use this better. And I do feel it's sort of integrating a public health and intelligence-based approach into clinical care and organisation of health and care. So preventative, different ways of working, being more efficient, better outcomes, and hopefully quality for people if this process works. But it will take some time to do that, and it takes some clinical time off to engage with some of the detail of the data as well. But I think the opportunities are there, and I'm the system lead for population health management along with our medical director at the Acute Trust as well. So we have a lot of people working on a 20-week programme to really test it in certain areas. So you'll hopefully be able to share some of the findings and sort of real impact of what's happened from those pieces of work, which have been helped through NHS England as well, to bring extra resources to help us, and we can then spread out the good bits as we go into the next years.
Thanks very much for that. Very full answers to that. I know the original question was a very long question, so I wasn't really intending to read it out, but I'm sure the questioner will follow up with you in some way if there's aspects that they want to follow up on. But thanks very much for those answers. Right, okay. There's a question just come in really almost in response to that. As a member, as a PPG member, what support is there in the ICS for GPs to educate patients, for example, talks at surgery network level to deliver support to patients on chronic illnesses to help reduce demand? An interesting question.
So I think there is money around to support general practice, and I'm not sure it's so much that we need to teach them how to do it, but we need to give them the time to do it. So when I worked in a community psychiatric mental health team, our general practice in Nottingham, our general practices in Nottingham had loads of resources wrapped around them: welfare rights, I don't know, Citizens Advice Bureau, somebody to talk to around low-level mental health problems, legal advice around divorce or separation or relationships, and they were available in the practice. And as we've moved on, I think we've lost a little bit of that. So I think for some of our practices, if there can be places where people can go and talk about what it's like to have, so I've got hypertension. I am very, very keen on making sure that it's controlled because I don't want vascular dementia like my mother. So if there are places where people can go and get advice on exercise and I don't know, dietary management and the best ways of dealing with their condition. Now, some of that is social prescribing, if we go back to what I spoke about earlier, but some of it is just around general practice, having a wide range of people working with them so that they can meet the needs of everyone, not just from a medical model.
Good, thank you.
Rachel's got hands up, Nigel.
Oh, Rachel, sorry, yeah. Rachel?
Sorry, my button is very slow, so it's easier for me to wave my finger around. No, I just wanted to sort of add to that. There's clearly a bit of a variability in what's available in primary care sort of areas. You know, an example where I think St Austell Healthcare is really focused on in their practice on bringing sort of patient sort of condition-based support, nurse-led or voluntary sector-led, or for example, the example of the National Diabetes Prevention Programme. But there's also a team in Cornwall called Healthy Cornwall, which is our health improvement team. So people in PPGs should be able to access a website I'll put in the chat, and they deliver a whole range of support for people with conditions to get more active and to address lifestyle. And I think this is, you know, it's a resource in Cornwall that is very sort of rare to have in some areas. So I think it does a lot of training as well for people who work in communities to help other people keep well that they're working with, whether that's mental health first aid or whether that's sort of how to talk about healthy behaviours. But I think we did a whole piece of work with the voluntary sector and with patients looking at support for people with long-term conditions, living with long-term conditions, and they said to us they wanted to have practical support, something like social prescribing, information on their condition, diagnosis, and then someone clinical to talk to about it and how to manage it, an action plan, mental health support, because often, you know, you're living with a condition that brings anxiety or other, you know, sort of conditions with it, and be healthy. And they were the things that they said very clearly from our engagement, our working in focus groups, that people felt they needed. And I've been trying to, you know, sort of convey that and work with primary care networks to ensure that's part of their model as well in the future.
Andy, you wanted to come in on this?
Yes, please. Just to say that we've done a piece of work with primary care networks, and I think we've probably we did something called active signposting training for the frontline staff at reception in particular, so that they understood what resources were out there immediately around the practice in their community, and what condition-specific resources were within the county that they could draw upon. And that, I think we did that with about 2/3 of the practices in the county in the end. And then I mentioned that we're developing a kind of voluntary sector model. I say we, I mean all of the voluntary sector working together on a model, and within that model, Age UK are presenting a place-based hub, and we are trying to make sure that they are linked to their PCNs, so that there'll be at least 15 place-based hubs, that because many of the practices haven't got the space to have the voluntary sector in, and particularly at the moment with COVID, we will site ourselves nearby, and then we will put all of that stuff in so that practice can say, oh, well, if you pop down the road, just across the road there, you'll be able to talk to a whole range of services. And so as those develop, so if any voluntary sector colleagues listening and you think, well, I don't know anything about this, it's embryonic at the moment. We're just working through the practicalities, the implications, and it's not about opening new places necessarily if there are already existing places. We are piloting it. We've started in Weybridge, using the concerned Weybridge Centre as a hub, and then we need to just build those links with the PCN in the area so that they know everything that's there, so they can just say, oh, if you pop along to our colleagues across the road there, they will be able to advise you on this, that and the other. And the last thing I wanted to say was that the concept of peer support is a kind of central part of that approach, so that if you so I mentioned breeders groups before, if you've got COPD, the best people to help you understand how to manage that condition are other people with COPD, and there are a fantastic range of organisations in the voluntary sector in Cornwall who have that lived experience, and I'm very happy to share it with other people. So I think this is an area where we will see big changes, and hopefully for the better in the coming months and years.
Very much, Andy. I'm really pleased you found an opportunity to mention reception staff and frontline staff, telephonists at surgeries. I think they're really important role at the moment, and often unappreciated, and often get the brunt of people's anxiety, and they do a fantastic job. So thanks for mentioning that, as well as everything else. I think I should move on now. There's a whole series of questions around the question of staffing. How do we get staff? How do we get staff to fill all the gaps, recruit them, to train them, clinical staff, carers, now and in future on a sustainable basis? And that runs over into the question of accommodation. That I know a nurse at RCHT who is likely to have to leave because of accommodation issues, emergency department nurse, which would be really, really tragic, obviously. And what can be done in terms of pay and job security and career development, the whole picture. But accommodation very often comes up as a central part of that too. So who would like to start on that? Zoe.
Yeah, thanks, Nigel. I'll start on the accommodation piece. So I think we all know the challenges that there are with accommodation across Cornwall at the moment. And we're particularly finding issues with people who are trying to come to the county to start roles and are just really struggling to find any accommodation. We do have accommodation available for staff, but the demand for that is well outstripping supply at the moment. So we are looking at how we can acquire some additional accommodation, not just in the short term, but also in the medium and long term, because we don't think this is going to be an issue that's going to go away quickly. And it's not just a challenge for us at RCHT either, it's a challenge across the system. So we are working with the CCG and the council to really review what we can do there, and essentially just try to acquire some additional accommodation that we can use. So that's just not a barrier to people coming to Cornwall. And actually in the future, it makes it a bit more attractive, because it's, it can be a big move sometimes, people coming into the county. But if we have a package that can help them settle in, set them up, we can give them accommodation. It just makes it much, much easier for us to try and attract that workforce. And then just on the wider issue around workforce recruitment and retention, it's huge, isn't it? It's a massive issue, because workforce is what we absolutely run on day in and day out. And again, it's not just a challenge for RCHT, but across the health and care system. And we're trying to get much better at when we think about workforce, not just thinking about our organisation, but actually thinking about the wider health system as well, because there's no point, stealing from Peter to pay for Paul. If we're taking a nurse from one place to staff another, overall, it's not helping the system. So there's something around how do we make it really attractive to work in Cornwall? How do we make our our terms and conditions something that makes it a place that people want to come to? How do we align our policies? How do we offer different career routes and different training opportunities? So something that's happening from next month, we're opening a new reablement ward called Wigglesworth. And on there, we're trialling a new approach to training healthcare support workers. So healthcare support workers will get around a batch of about 18 at a time, and they'll train for 6 weeks on that ward, and they'll get their certificate, and then they'll have the opportunity to rotate and work in different areas across the system. And so really trying to sort of have those innovative approaches to training and development, and again, not just an RCHT approach, thinking a bit wider. I don't know if anybody else wants to come in on that one as well.
Anybody else?
So I think the issue of one of the things that the integrated care system is going to have is a single workforce plan for Cornwall, and that is doctors, nurses, OTs and dentists. But it's also the supply into care work in people's own homes and in residential and nursing homes. And we're being asked to work with social care colleagues to make sure the social care workforce is referenced in the One People plan for Cornwall. There's been quite a lot of exciting work that's happened over the course of COVID and beyond, where the banks for RCHT and CFT have worked together to help care homes to stay up and running, because it isn't always care staff they need. Sometimes it's I don't know, a cook, a chef, a porter, somebody in one home. It was just to make sure that everything was in the rooms when people were going in, because when somebody's infected with COVID, you can't pop in and out of a room, you just need to stay there and have everything that you need. So our understanding of the interface between health and care has got a lot better. I'm asking somebody to come and do a piece of work for me to look at how we can have a single offer around training, development, skills and supervision for Cornwall, and that will mean that hopefully over time we can offer free training to our social care colleagues in people's homes and in bedded areas. And we might even over time be able to offer support around CQC registration and reviews, because they're the things that small organisations find it difficult to do. So I think there is lots that the public sector can do as anchor organisations to support colleagues in smaller places to do really good jobs. And I think there is just something about the perception of care. So one of our NHS colleagues, Alexandra Dudson, challenged us really strongly about who we look to and who we look for when we're thinking of a care worker. So I just want everybody to imagine what they think a care worker looks like. And then her riposte back was, I see lots of people in Cornwall with multiple piercings. Some people have pink, purple or red hair. Some people have got, you know, they wear clothes in a different way to your core NHS staff. Are we saying those people aren't welcome to work in care? And of course the answer is no. So how we advertise, where we advertise, how we make ourselves flexible around working 16 hours a week, or working only weekends, or working only nights on a Thursday and a Saturday. We have to think about how we make ourselves an attractive place to come and work. Because as I say, there is nothing more joyful, I'm trying to think of a different word that doesn't sound quite so soppy, than knowing that you've helped someone. It's quite a selfish occupation actually, caring, because you walk away thinking, I've made a difference, this is great. So we are thinking about all of that, and our People's Board for Cornwall is going to get a bit more bouncy and vibrant. So if any of you would like to join us for even just to see what we're doing, you're very welcome. And if you've got any ideas, that would be great. Can I just pick up the care hotels and the stuff around living carers? If we can market the idea of living carers to people in Cornwall, market's a horrible word, isn't it? Explain how it might work for them, then I think that would be great, because people get a home as well as a job. So somebody who's anonymous in the chat has got experience of doing this. So it would be great to talk to you about how we can explain to people the benefits for them. And the care hotel, and that is we're looking at opening one in a couple of weeks. That will be employed by out-of-county workers, because at the moment we need to bring people in quickly, and we've got a bit of a holy storm actually of COVID rates being quite high in the county, people still being poorly. Therefore, we've got lots of sickness in services. We've also got hospitality still paying more than care worker salaries, and therefore people are choosing, as would I, to have more money in their pocket by working somewhere where they get paid more. And we've also got some organisations who are finding it difficult to continue to function because of cash flow through COVID, having to keep beds shut because they've got wards, units, services closed because of having people who've got a positive diagnosis of COVID. So all those things are making it super challenging this year. We're also talking to our third sector, so not volunteers who don't necessarily expect to be paid for the work they do, but for people who we may pay, who come from a non-statutory background. That then comes back to who's in your local community, how well do they know your community, and how can they respond to your needs. So that's the dialogue we're going to have through our primary care networks and into neighbourhoods, because it's going to, some places it'll be a street by street conversation, and that can't be done once from Cornwall and the Isles of Scilly. But if we say the money's available, then I'm expecting people are going to tell us how they'd like that money to be spent.
Okay, thank you. And move on to a question that was asked really early now in the chat. In the course of this meeting, I'm delighted to say I've had a message saying I'm now eligible for a booster and I should make an appointment on one of the other screens that's working. The question earlier on, so as soon as we finish, I'm going to do that. The question that was asked earlier on was, going forward, the vaccine programme is not as successful as it was. Walk-in clinics where you don't need appointments have stopped despite being very successful. Many people have to travel a long way now to get a vaccination. Will the mobile clinics restart? And since I live within walking distance of the Old Stithians Mass Vaccination Centre, that's a question of some interest to me as it's not there. I think that's one for you, Rachel.
Thank you. So, I mean, I think when we say it's not been a successful vaccination programme, I would take that to task. I mean, we still have very good uptake overall. So, you know, the latest sort of, or I think the end of last week's data was we have 83% have had all of their first doses compared to 85% in England as a whole. 78% at the second, similar to England, which is the same. So we do have good coverage. Clearly there's a sort of hesitant sort of remainder of people, and unfortunately we are seeing them, you know, being hospitalised. So, you know, every opportunity we're getting, we're saying clearly it's an effective vaccine, please come and get it. The rollout of the booster or the third vaccination for people is continuing. So they are, if you haven't been invited and you're eligible in the 1 to 9 category, you will be invited. They are being offered through a whole variety of means. So there will also be mobile vaccination, or our mobile vaccination teams that are deployed in areas where the data shows that there is a lower uptake, and particularly where there may be as well some sort of higher COVID cases. So this is always tweaked and as part of a sort of live sort of logistical arrangement with the teams going out. And there are additional pop-ups for care home staff as well who haven't had their full vaccination. So there's a huge amount going on. So I think it's not fair to say that this programme isn't doing all it can through working both for NHS, community colleagues and voluntary sector, public health. We're doing, I think, a pretty good job at looking under every stone to see if we can ensure people can access. It is a rural area. It is a real challenge to make sure that everything's accessible. The 12 to 15-year-old campaign, so it's being mainly delivered through school vaccinations, but in addition to that, people who aren't able to change their mind can then also go and for appointments at the Health and Wellbeing Centre and Weybridge Showground. So there are a whole variety of options, and most of the there are also sort of other additional things to help people, such as free rides for like a Baxi taxi, we've called it, for people working in care homes. So there is an extraordinary amount still going on and still to do, and I think I would sort of just encourage you all to be supportive of your communities to take up the options, and all full information is available on the CCG website if you go to that, around vaccination clinics in your area. So yeah, it's been a challenge, and it will continue to be a challenge, but it's just so important that we support the programme and share that positivity with our population.
Thanks, Rachel. Andy, you wanted to add?
I was only going to mention the Baxi taxi scheme, but Rachel's mentioned that. So if you are struggling, because of the cost of transport from a rural area to get to a vaccination point, then we ourselves and Age UK operate a Baxi taxi scheme, and we can come and pick you up, take you for your jab, and take you back again.
Thank you. Okay. Where are we? Coming up to 12 o'clock. I think one of the themes that I've picked up from this is communication. Really, that there's a huge amount going on. There's a lot that I didn't know about. And I've spent some of my life going to meetings about health, really, and I'm sure a lot of the audience do. And I think there is something to take away, that how do we get that all communicated? We put out various messages and various bits of paper. Do we measure whether they're actually reaching the right audiences, enough people to know where they can go for help, where they can go if they want to offer help, and so on? So I think there's a conversation to be had about the whole question of communication in Cornwall, about all the things we've been talking about today. Now, there's got a couple more questions just come in. Let me have a look at this. Bear with me a moment. One's about pop-up services where people can't drive, and also housebound people. Issue for housebound people in the community receiving their boosters. GPs don't have the time to do it. Can mobile teams help with this?
Yes, Nigel, so I can answer that briefly. I mean, it is something that's been identified, and the multi-agency vaccine team is deploying some plans around that to support GPs, and that could include 2 additional sort of mobile vans to do that. So yeah, it's certainly been an issue for this time round, knowing that the pressures that primary care are under. So support in place and being mobilised.
Thank you. Okay, I think we're through all the main areas of questioning. There've been an awful lot of questions and comments in the chat, in the question answer column, which are really useful. Some of them are sort of detailed, following on from earlier answers, and I think we should leave those to be answered in writing subsequently. And as I said, that will be up on the website, and individual questions will get individual answers, so they'll all be dealt with. I don't think there's anything too difficult, hopefully not. There's a point about case management. Kate would like to respond to that. Let's deal with that.
Hi, somebody put in the chat that when I was talking around us moving people into bedded care, and I was talking about we'll case manage people into the right place. And I was challenged about that being an old-fashioned way of looking at case management. And I think there are 2 things that are running at the moment. One is the necessity for us to move people into the best place as quickly as possible. That probably isn't their final destination. It's probably not the place they should be, but it's a better place than they are now. And in doing that, I think we've got a responsibility to make sure that we track them through the system, and that is old-fashioned case management, making sure that we get them to the best place that they can be. The point that was made in the chat around high-intensity users and social prescribing is exactly the point around person-centred care, so that we are working with people on the agendas they want about the things that will make their lives better. And I think we're going to have to do both at the same time. And it comes back to the fact that the agenda that's been set for us in a post-COVID world where there isn't enough funding because we're a public sector service is difficult, and that we are going to have to make choices around how we do things. And for me, one of the things around making a choice is being prepared to explain why we've made it, and involving people in making that choice the best it can be. So I just wanted to explain that I think we're going to have to do two things at the same time: bottom up, and then managing a system that frankly at the moment is a bit chaotic. And for everybody who is receiving care in it and working in it, I every day feel really sorry that we're asking people to experience care in the way that we are, and we're asking people to work in care in the way that they are, because it's soul destroying for everybody. We need to do something quickly to reset the system, and so I just wanted to explain that, Nigel.
Good, thank you. Yeah, there's a comment. Government-funded support for adult social care services is significantly lower in county and rural areas. This creates health inequality locally. What can Cornwall Council realistically do about this? Well, I'm sure Rachel would love to have the answer, but probably we'll get lots of goodies in the budget, later on. Andy, Rachel, Kate, any final thoughts before I draw this to a conclusion?
Can I just say that you know, I've worked with this lovely bunch of people for quite a long time now, and one thing Kate always says, which stuck with me, is that we work in this across the health and care system, but we also have family and friends, and we ourselves are potential patients of this system. And I think when I first met you, Kate, you said something about building the kind of system we would want to experience ourselves. So I think it's incumbent upon all of us to keep that at the back of our minds as we take part in things like this, and as we're all involved in the day-to-day delivery of or transition of our services, that we're trying to make something that we ourselves would want to be part of and be on the receiving end of at the end of the day. And in that sense, there's a role for everybody in Cornwall to play. So everybody on this call is probably already highly engaged, through PPGs or through their day jobs in the health and care system. But there's a whole group of people out there who don't really think about health and care until they need it, and we need to get them engaged and involved in all aspects of that, for themselves and for the people they live with and around, ASAP, really.
Rachel, final words?
Thank you. I mean, that's lovely to hear from Andy. And just quickly, I suppose I would add that this is an opportunity to build on some of the real positives. I think let's not go back to everything business as usual after the pandemic. Please let us learn. Please let's move forward and do things differently, which I've really heard from Kate that she also wants to do, and it's really heartening. And also I think as we've all said, let's just not forget the 20% who often very unfairly and unjustly have very poor health. And that this is something that we should always, as a system, being committed to address as a priority as well. So heard lots of positive things, and it's really good to have the questions and engagement from the conference. So thank you.
And Kate, anything to add?
Just thank you. I always find things like this really, really stimulating and challenging, because no matter how hard we try as public servants, we'll never always get it right, because to be human is to err. And Andy's point around one of the compelling things for Cornwall for me is that we are looking after people that we love. We're looking after our neighbours, our family, other people's families. So it should be really, really personal. and that should drive us to be the best we can be.
Good, thank you. Well, I think leave all the remaining questions to be dealt with subsequently, but thanks to everybody who's asked the questions and commented in the chat. There's a lot to learn from all of that. So thank you for coming along and staying with us, and thank you for contributing in that way. There's a final question about how the second session will be organised from somebody who couldn't get in early on. We'll put our date out. It will be more of a workshop format, so we'll probably divide people up into workshops a bit and so on. Some of it depends whether John Gavett can join us on the day. We don't want to leave it too long, but that's broadly what I'd say. It was intended to be mostly workshops. It will still be mostly workshops, but we may tweak it a little bit, and we'll let everybody who's here and everybody who put their names down for this know the date as soon as we can. Obviously, if you've got further questions to ask, send them in to the various places you can send them in, or follow-up questions or whatever. I'm sure it's like funding. Never get enough money, you never get a complete answer to your question, but keep digging away and you'll get nearer. So finally, thanks to all our speakers, to Rachel, to Kate, and to Andy, and to Zoe also, for all your time and all your preparation and contributions. Thank you very much for all of that. And finally, thank you to everybody in the background, to Ben, to Pete, and to Louise, who've kept us on track for the last hour or 2 or 3 hours. So thanks to everybody. Enjoy the rest of the day. I'm going to go off to book my vaccination. So cheerio for now. Bye.